This podcast is sponsored by PAX. Whether on the water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Their well-organized compartments and customizable configurations enhance efficiency in high-stress situations. They're designed with infection control in mind and are easy to clean and disinfect. So highly visible colours and reflective strips aid quick identification and adherence to quality standards, ensuring reliability. So the versatility of PAX bags caters to diverse EMS providers, and they deliver vital equipment, durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations, and they're absolutely excellent, both in identification of kit, but also in identification of the reflective strips to ensure visibility. So please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking about decision-making in high-pressure environments. So this is going to be slightly different to normal episodes where I'm going to give a lecture, and it's going to be based on a lecture I gave for an air ambulance recently for their clinical governance day. So what we're going to do in the episode is really just examine decision-making in high-pressure environments and why it's important as a central concept within pre-hospital care. We're going to look at a case study, we're going to look at definitions and theories, we'll look at some of the common pitfalls of decision-making. We're also going to look at AI, so artificial intelligence. We're also going to look at some of the trends and indeed the summary. This is going to be a YouTube video as well as a podcast, so please head over to the YouTube channel to just search Pre-Hospital Care Podcast, and it will be there given as a lecture on the YouTube channel. It's also just prudent to say that the case study within the episode is of a patient whose information is fully in the public domain. So Dan Richards is a patient I attended back in 2009. He has publicised his case both on the BBC, Channel 4 and a few other various media outlets, and I'll put those in the show notes, but it's just prudent to say that all his information is out in the public domain, and I also have permission to share his information in this episode. So why is decision making important within pre-hospital care? And I think this is one of the fundamental aspects. So in essence, you have limited time in pre-hospital care, certainly from a critical care perspective, certainly if the patient has a significant injury load, whereby if you do not intervene in that physiology, there is going to be implications and ramifications. So there's either limited time from the consultation or indeed from the patient themselves. There's a certain amount of uncertainty. So there's a large amount of variation in each incident from the environment, indeed from the scene dynamics, crew dynamics, team dynamics, but also the human factors. So fatigue levels, time of day and night, and also the patient presentation. And then thirdly, there's information overload. So this sensory and cognitive overload, which can really start to skew decision-making, because it's prudent just to understand which information to take on board, which information to pay attention to. So the case study I'm going to start with in the story is that of Dan Richards. So in May of 2009, I met Dan Richards. And so he was part of the British military, serving in various places in the world, but he was back in the UK in 2009. So Dan had a significant injury load. He'd come off his motorcycle approximately 60 miles an hour, catching his right arm and shoulder on the central reservation and coming from 60 miles an hour to zero in almost less than a second. So the summary of Dan's injuries were he had a neck flap with great vessels showing, so I could actually see his trachea. I could see his external jugular vein. He had a complete right arm amputation, incomplete right shoulder amputation, blood loss all across the floor. The left ulnar open fracture, bilateral fractured femurs, and they were closed. He was GCS 15, so he's fully alert and in extreme pain. The reason I choose this case study is really that The decision making on scene was difficult because he was in so much pain. The pre-hospital team were really struggling to proceed with any kind of formal procedures or or skills on Dan because he was in so much pain and they couldn't really get him out of that pain. And so there was really almost a rate limiting step that Dan was obviously screaming in pain, had a high burden of injury, and we first thing we did when we landed on scene with London Hems was really give him a large bolus of ketamine to sedate Dan, and really just start to facilitate good decision making on scene, start to facilitate closed loop communication, share plan A, plan B, and plan C, really start to get 360 access on Dan, and then fully appreciate his injury load and put a plan in place. So it's prudent to say that we weren't sure when we were with Dan whether he was going to survive or not. So we gave him a roadside anaesthetic, flew him back to the Royal London. Dan had some damage control surgery on him. He had a right arm and shoulder full amputation and damage control surgery. He made an amazing recovery, actually. Went to Headingley Court to have his convalescence and rehabilitation. And we saw Dan up at the helipad, what would it be, probably 2 to 3 months afterwards in a wheelchair, undergoing an amazing rehabilitation journey at that time. The case really was this real semblance of decision making in the moment, quick decision making, quick enacting the plan, but also making sure that we delegated a lot of the decision making which we didn't need to make, and this is really important. And we'll talk about this later in the episode about delegating and focusing on elements which maybe only you as a team can deliver. So let's just step back slightly and look at some of the definitions and theories. So the first definition theory I'd like to broach is that of heuristics. Pratt-Cantis stipulated that heuristics were, in essence, something we use as a mental bypass when we have too much information on scene. So something we can rely on when time to make a decision is limited, when there's too much information on scene, when we have to make a decision as part of a bigger system of decisions. Also, when there's very limited access to information to make decisions, and also when we've been in these situations before. So heuristics aren't necessarily bad things. They certainly guide us in a lot of practice, but in essence, they don't always serve us that well. So it was first posited in 1989, and we certainly rely on heuristics a lot of times. But it's prudent to understand some of the heuristics we rely on that they don't always serve us well. So human bounded rationality, this was posited first in 1957, and this really was around two aspects of decision making, that of satisficing and also that of environmental. So satisficing is really an element of choosing information which is good enough. So we don't have access to all the information on scene at that time, but we have to sometimes suffice with what we do have and make decisions going forward with the patient presentation, some of the history, or indeed a handover from the receiving clinicians, and that has to be enough information sometimes to make a plan. So we may not have all the information, but we make decisions based on what we do have. So the environmental factors that were posited were really around looking at the complexity of information, changing the dynamic environmental aspects, so that actually there is a time pressure, but there's also a noise element, certainly when it's in pre-hospital care and it's changing. So weather, noise, and all these environmental pressures, resource limitations as well, and social cultural changes in the environment, all will guide us into certain decisions. And this is around trying to make bounded, rational decisions with the information we have. So Gestalt theory was first posited in 1920 by Max Wertheimer. So principles of Gestalt theory are around proximity, similarity, closure, and continuity, and also simplicity. And that really is around that we look within our visual field to the main object of focus, and then to the ground. So we really are unilateral in our focus. We is proximate. So what we do is we look at objects close to each other and perceive them to be as a group. Similarity. So what we do is look at elements that are similar and that seem seen as part of the same pattern, so that we look for pattern recognition wherever we can find it. Closure. So we our minds fill in the gaps from missing information to perceive information as a complete image. And we look for continuity, and that is really around lines and patterns that are perceived as continuous. I mean, we also look at simplicity as well. So this is about simplifying complex scenes to make sure they're in their simplest form. But fundamentally, Gestalt is about stepping back and seeing the whole patient and indeed the whole scene. So you're cognizant of the bigger picture. Whilst being able to zero in on some of the details, you can step back and step forward and manage to see how the mechanism of injury relates to the injury load and indeed how the patient is presenting over time according to the treatment given. And the next theory was inattentional blindness, and this is posited by Daniel Simons and Christopher Chabris in 1999. This was the dancing gorilla theory that was evident in the Stanford literature and testing. And this was really around a group of students which were sat in front of a video. They were told to count the passes for the basketball over 30 seconds. 70% of them failed to realize the dancing gorilla, which occurred around about 15 seconds into the scene. But the fundamental tenet here is that there is an inattentional blindness to what you're not paying attention to. They replayed the video and everyone then saw the gorilla and counted the passes. They said, "Did you see anything else?" Everyone said no. And what they'd actually done is change the color of the curtains in the background. What this really does tell us is that we are unilateral in our attention. So we're not bilateral or multilateral. We can't process multiple facets of information at one time. Therefore, it really is prudent to understand this bias in our minds, in our short-term memory, and then ask, are we missing anything? Because we will always miss things we are not looking for on scene. So next theory is around metacognition by John H. Havel in 1976. And this was really about thinking about thinking. So the term actually literally means above cognition. And this is really around being able to think in the moment and reflect upon your thinking, reflect upon your biases, reflect upon your heuristics, and actually catch yourself in the moment around different ways of doing things, different ways of operating, and indeed changing if it's not optimal. So it really is about optimizing in the moment and understanding the way we're coming across to the team and the decisions we're making in the moment as well. So we do this in the moment. We look at metacognitive processes retrospectively within governance systems, but it really is prudent to be able to do this in the moment and really reflect in the moment so we can change the trajectory of care. So next theory is around thinking fast and slow from Daniel Kahneman in 2011. And this was really around two systems of thinking. So system one thinking is really around something that Daniel Kahneman posits we do about 90% of the time, which is we're in automatic mode. We don't give much effort to automatic thinking. It's very instinctive. It's quite quick. It's emotional. It's very much unconscious. Some classic examples might be tying a shoelace, sometimes driving a car, if that's something you've done for a long time. Also, just things that you do on a daily basis. System two thinking is much slower, rational, conscious decision, logical, and it often relies on you being intentional. So there's a certain amount of intentionality. There is an aspect of complex decision making that requires system two thinking, but because it's effortful, we only do it between 5 to 10% of the time. It really is not a regular part of our day. And what Daniel Kahneman posits within Thinking Fast and Slow is really that we should enact system two thinking in more of our day. So really start to be effortful in our decision making in more elements of our day. Really understand that, have we optimized for communication? Have we optimized for decision making? Have we optimized for patient treatment? Are we optimizing in intentionality, in consciousness, in very much a rational way? It is slower thinking, but it's prudent to slow your thinking down sometimes to speed things up on the other side. The next theory I'd like to talk about is signal detection theory. And this is from Gustav Fleckner in 1940. And this was really about looking at how individuals distinguish and discern between meaningful information and noise or background information. Really is looking at how easy or difficult it is for someone to process information and respond when they're being exposed to a lot of background noise or indeed needless distraction. So this can very much be extrapolated to pre-hospital care, where you have to make the distinction between what is the true signal, what do you need your inattentional focus on right now, your unilateral focus on right now, what is the priority for the next decision, the next right decision. Sometimes it's prudent to be able to step back and delegate decisions and declare the plan, but fundamentally sometimes it really is, certainly when you're first approaching a scene, to understand what the signal is against the noise. And that might just be listening, active listening to the handover. It might be understanding that the airway is the attention. It might be understanding that you actually need to mitigate or minimize noise on scene as much as possible to get a semblance of decisions and be able to appropriate the right decisions on scene. So the next concept I'd like to look at is from Ian McGilchrist in 2009. And this is around the divided brain. And what Ian McGilchrist posits is that there is, in essence, a right hemisphere and left hemisphere view of the world. And that actually there is a significant difference between functionality of the right and left hemisphere. Some of them include both functions. So speech is actually found in both areas of the brain. Imagination is in both areas. But there is actually distinct elements to the right and left hemisphere. The Imagrucus posits that the difference between the right hemisphere gives a sustained, broad, open vigilance and alertness to the larger scene, whereas the left hemisphere gives a narrow, sharp, focused attention to detail. And people who lose their right hemisphere have got a pathological narrowing of their window of attention. But one of the things and elements that is prudent to understand is that left hemisphere really is about sharp, focused cognitive skill, whereas the right hemisphere is certainly more focused on the larger, broader scene. And within pre-hospital care, we have to really be able to step back in and out of pre-hospital care. So we have to be able to focus on some of these fine motor skills, but also be able to step back and look at the wider scene and appreciate the wider scene as we're moving through the incident. Now, this requires both sides of the left and right hemisphere, and it requires a global overview, and then it might include some quite fine motor skills on the back end of that. Ian McGilchrist also posits that we have to triage and filter information all the time within our daily life, and that indeed the corpus callosum that separates the left and right hemisphere is actually got a function of inhibition more than prohibition. So it actually inhibits information and neuronal relay from the left to the right, and that really, so that the brain at an anatomical and pathophysiological level is also already inhibiting information so that we can retain a global picture from the right hemisphere whilst being able to do fine motor skills with the left hemisphere. And it's really prudent to be able to triage and filter information appropriately in pre-hospital care. What we need to do is really understand this and utilize this function appropriately. The next theory I'd like to mention is George Miller of 1957. And Miller posits that the human brain, or indeed the short-term memory, can only really hold 7 pieces of information plus or minus 2. And so we can see a graph here that actually when you start to overload the brain from more than 7 pieces of information to then 8 to 9 to 10 to 11, retention really drops down incrementally and then exponentially to almost zero, because the short-term memory from the dorsolateral prefrontal cortex really cannot retain large pieces of information. So that's important for a number of reasons. It facilitates good decision making when we don't overload people with too much information. And this is extremely important both in handover and also when we are communicating on scene to facilitate good decision making. So chunking information is absolutely key. And what we'll do in the show notes is put some links to well-defined chunked information such as S-bar handovers, whereby retention is much greater when we chunk information down. Retention from the receiving clinician or receiving colleague. And so we do chunk information naturally. Everyone does it, hopefully naturally, as they recite maybe their phone number or key information. But we also do it within pre-hospital care, and this facilitates retention. It also facilitates understanding. So next concept I'd like to look at is that of OODA loops. So Colonel John Boyd, 1976, from the US military, posited that OODA loops are a natural psychological tendency that we come to meaningful decisions by. And this is really around observing, orientating, deciding, and acting. So the observations are the jumping off point to decision making. This is really about multimodal information and how we interact with that information. So outside information, unfolding circumstances, unfolding environmental information. And then we orientate to that information. And this is about synthesis and analysis of information and how we make sense of that. And that feeds into decision making. And then we act on that decision. And then we go back to observation and go continually through these OODA loops. I just like to say that here that in the OODA loops, the orientation is often the most difficult part, because this is the critical analysis and synthesis of information. So this is often the most difficult and challenging part of decision making, and can often not just delegate but share with others. So you can almost verbalize your observations and come to shared orientation, and then a semblance of shared decision making on that basis. So maintaining the bigger picture is absolutely key within decision making, and really is something around not only shared situation awareness, but also understanding and comprehending what will happen next. So, and also verbalizing what will happen next. So, actually declaring and decreeing to the team, just verbalizing to the team what the next steps are. Using closed loop feedback to do so, looping for understanding. So, making sure that others understand what you have said. And then also something we're just going to broach shortly, which is MDTs, so multidisciplinary teams, and how multidisciplinary teams interact with decision making. So some common pitfalls in high stress environments. This is really around looking at some frequent flyers within biases that we hold. So one is confirmation bias. And this is really sticking to initial assumptions just because it's information we're comfortable with. We may have seen this in the past. We are guided by maybe limited information that they've come up with certain results in the past that have worked for us. So we are quick to jump to these biases. So confirmation bias is a large part of people's practice. And it's prudent to acknowledge that in oneself. Another would be overconfidence, so ignoring critical information or input. This really speaks to the Dunning-Kruger effect, around having less information, less experience, and maybe too much confidence, as opposed to more information, more experience, and maybe less confidence in the outcome and indeed in the inputs. Groupthink is a common pitfall within high stress environments, and that really is around complicity, and indeed failing to explore some of the alternative options. Around maybe you're thinking something different. It's prudent to verbalize that to stop the team from falling into either confirmation bias, overconfidence, or indeed the wrong plan for the patients. And then another common pitfall would be loss of perspective. And this is maybe focusing on one aspect of the scenario where it's not necessarily the whole scenario, it's not the whole scene, it's not the whole information. And this can actually occur quite frequently when a clinician gets overloaded. So someone who's leading the scene starts to go in to do a fine or indeed gross motor skill that doesn't go so well. So a classic case would be intubation, where they can't intubate because it's a difficult intubation. They lose the meta perspective or the overall perspective. And it really is about either pulling them back or indeed taking control of the scene so that actually there is someone running, still pushing the scene forward in the background. Next, what I want to look at is AI, so artificial intelligence, and how this is really shaping decision making in principal care. So what we're starting to see is large language models to supplement patient narrative, which is fantastic. And what we're starting to see within different physiological monitors now is prompted differential diagnosis based on trending physiology. So what we're starting to see in software is that in up and coming devices is that they're starting to prompt certain differential diagnosis just to prompt the clinician to consider them. So again, not relying on heuristics, not relying on confirmation bias, or indeed on the clinician's finite attention, but starting to look into the trending physiology and prompt the clinician from there. We're also seeing um, QR scanning of drugs on scene via monitoring. So actually scanning the drugs from the ampoules into the monitor. This is a key facet, so that actually there's timestamps of those drugs, but the clinicians don't have to go through multiple pages on the monitor to stamp those drugs in. And it also is fed back to the pharmacy on the back end to refill the pharmacy. But what that does from a human factors perspective is logs quite quickly and also confirms to the clinician that it is the right drug they're giving. So it's cross-checking of drugs with the monitor. But it's prudent to be able to do that with clinicians, but also we're seeing that within the monitoring as well. And there's also a semblance of deep learning, which is occurring within AI. And this is around hypertension tracking, which is already occurring as preemptive warnings, where we're allowing AI to really monitor subtle changes in maybe diastolic blood pressures to really preemptively warn clinicians of any trending changes. So tools for decision making, some strategies that foster good decision making. This is really around starting to delegate some of the cognitive burdens on scene. This is through checklists, and checklists are well known to reduce cognitive load. Stress inoculation through gradual exposure. So this is often something common to pre-hospital care around gradual exposure to stressful scenarios through mentorship and through actually starting to share the burden of information and indeed decision making with the team. One of the key concepts for decision making is putting it into the cauldron of training and simulation. So really starting to train hard, fight easy. So really start to mimic and make training quite exacting. So improve the fidelity of scenarios as well to really start to test decision making in analog environments where you can start to really discern how that decision making was fostered. Recording the training as well, so recording the decision making and looking back at that, really going into debrief and understanding were those decisions appropriate in that time. And then team cohesion. And this is really learning how you as a clinician and how the team communicate under pressure. And again, this can be simulated and this should be reviewed post simulation, but also in practice. And this can be reviewed um, in both D&D, so in both in governance days, death and disability, and clinical governance meetings, where you can start to unpick decision making. You can also pick it in the debrief as well as to how you came to those decisions in practice. Debriefing is an essential part of any simulation, and you should take as much time in debriefing as you do in the actual simulation itself. And it really is about understanding decision making from the debrief and unpicking some of those decisions retrospectively, understanding why the clinicians made those decisions, and letting the room inform the clinicians as to how that scene was managed, how those decisions were made, and then unpicking it from the clinicians as well. So shared decision making from MDTs, and this is really a facet of something which is becoming more common within prescribed care, is around multidisciplinary teams from a community of practice. So this would be around looking at a multimodal digital display, almost like a FaceTime call with clinicians, reach back clinicians, with clinicians from major trauma centers, with clinicians from heart attack centers, from stroke centers, and indeed from maybe EOC, so emergency operation centers, where you can start to share decisions with the wider team that maybe aren't unseen. And this is really starting to come into the fore as it's enabled by both technology and AI, and indeed platforms which share data and indeed FaceTime. So something just to say as well, which is absolutely key, is that names are absolutely key to good decision making. What I mean by that is sometimes the most valuable part of a well-run scene is making sure that you attach decisions and requests of the team to names. And that it is a cognitive burden to remember someone's name, but it's absolutely key to foster both good cohesive team working and also just to label the attribution of a task to that person. So using names, trying to remember names is absolutely key. There's another concept I'd like to look at and talk about around homeostatic teams. And this is really the skill of keeping the conditions of the team constant. So maintaining a stable internal condition over a high performing team, irrespective of unstable and or unpredictable external conditions such as weather, such as noise, such as team dynamics to the wider team. So this is really about maintaining homeostasis within the team and within the meta team really, so that there's a calm, consistent, controlled communication going forward, and that there is clear lines of communication, but there's also clear lines of decision making. Um, and it's about bringing that homeostatic team with you wherever you go. It's good just to mention that trust equals cohesion, and what we want to do is build trust quickly within teams. This jumping off point to trust is often active listening, and this increases rapport. Rapport increases trust, and trust increases cohesion. So you know when someone's been active listening because there's a semblance of repetition, or indeed they can bring information that the communicator has mentioned earlier on in the communication back into the communication, and that shows the listener that they are fundamentally listening. It can build trust quickly, and cohesion. Quick cohesion is absolutely key to good decision making and good semblance of high performance. Graded assertiveness is another aspect of good decision making, and this really is around recognizing when someone's cognitive and or mental capacity has been reached. And this so the graded assertiveness acronym here is PACE. So it's probe, alert, challenge, and then declare an emergency. And this is really around understanding when someone has lost their faculties of listening, of also of peripheral vision, of concept of time, and they're really starting to become overwhelmed mentally, to bring them back to a place of good decision making. Um, the place to be really is an element of understanding that you are going to lose cognitive bandwidth if you do perform quite a fine motor skill, which is quite challenging, and then verbalize that ahead of time and delegate maybe the wider decision making, the wider scene to another colleague. But here, this is a really good tool if you are noticing someone is going down the hole or indeed the funnel um, of losing their bandwidth. So some of the lessons learned here is understanding some of the facets of limited time, task focus, team leadership, and bandwidth. When to bail out and when to just really pull back on a scene and understand that the cadence decisions really needs to improve. You really need to really push this scene forward. So also when you're becoming task focused and to keep a check of priorities, look at also team leadership and delegate leadership if you are becoming more engrossed into fine motor skills. And then looking at bandwidth, and that really comes with practice, both on scene, in clinical practice, but also in simulation. So another facet of good decision making really is around limiting the amount of information on scene. And there's no better place to mention this than in multi-patient scenarios, so mass casualty incidents where there's multimodal information, multiple patients, some really challenging, stressful situations and decisions to be made. So we've seen the 10-second triage tool, and indeed the MIT, the major incident triage tool, come into effect. And what these do is they really limit decision making. They make decision making easy. And the real adage here is that you don't just need to use them in mass casualty incidents. You can use them in any multi-patient scenario within a road traffic collision, or indeed on any scene which mandates more than one patient, just to mitigate some of the overwhelming information that you might be faced on scene. Also, as clear signage to other clinicians that this patient has been triaged and that they can take and enable good decision making based on the decisions in front of them. So what we want to do is really start to limit the information or triage appropriately so that we can make better decisions when there's almost too much information, too much sensory overload. So in summary, it's prudent to understand that we have heuristics and biases as part of our practice, and they're not always a bad thing. They serve us well 9 times out of 10, but it's also prudent to understand that actually we recognize those heuristics and biases for what they are and that they don't always serve us well. And that there might be another way of doing things, both in the moments and learning from simulation as well. It's prudent to test as a team. So just walk through as a team through simulation, some of these decision-making processes, just to understand how you make and come to good decisions in simulation. Spend quality time in debriefing to understand decision making retrospectively. Then reflect as a team on technical and non-technical decision making to understand rate limiting steps and indeed some of the aspects which didn't foster good decision making. And then look at how you did come to some good decisions. Then look at understanding and understand our own inattentional blindness on scene. This is really, really important to understand that you were only really unilateral in your focus. No one could be multi or bilateral. So no one can focus on two things at once or multiple things at once. Therefore, we are going to miss things on scene. And have I missed anything is a powerful question to ask. Chunking information for others is also key because actually it fosters retention and better decision making in other people. Using names attached to decisions just to foster better reciprocation and indeed execution of those decisions. And finally, looking at learning around decision making and learning that sometimes it's prudent to disagree agreeably. And this is about making sure we don't fall into groupthink all the time, but also that we come to the best decisions. And that if there is something that the senior clinician or indeed the leader is missing, it's about speaking up to make sure that they are aware of that. And that actually, if we disagree on scene, that's okay. And it doesn't mean we disagree fundamentally with the person. It's just that we might disagree with the plan because they may have missed key information, and that is okay to disagree agreeably. And then to actually make sure that we come to a defined endpoint together. That is a lecture. I will put in the show notes all the links to the theories and indeed concepts which I mentioned within the lecture. They will be in the show notes for you to research and check out of your own accord. I hope you enjoyed it. It was really great to just do a deep dive into decision making and understand some of the central aspects of decision making that really inform our practice, and also just be aware of how we can make better decisions in practice. for patient care. Thanks again, and we'll speak to you soon on the podcast.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.